be chairing the first session. Just want to introduce our first speaker, Dr. Louis Lau. So Dr. Louis Lau graduated from the Chinese University of Hong Kong in 2012 and thereafter obtained his specialist registration. His research interests are in GI bleeding, advanced endoscopy, big data analytics, and AI. And he has published in high-impact journals such as NEJM, Gastroenterology, and Gut. He's an assistant professor and has much experience in AI and is a personal friend of mine. So without much further ado, I'd like to welcome Louis to start his presentation.
Hi, good morning, everyone, especially to our international friends, Sano Sensei and also Noria. So welcome to Hong Kong again, and also, of course, James. So thank you very much for attending this NU workshop of CHK and ANBIIG. And to start with the morning section, I'm going to talk about a kind of a new topic, but it's a very hot topic. So it's about AI. So in the first session, we would discuss how should we, as clinicians, to embrace the massive wave of artificial intelligence like the ChatGPT, everything else. And today I'm going to talk about the new roles of AI in luminal endoscopy as well. So these are my disclaimers and disclosures. So first of all, what is artificial intelligence, AI? So it is actually a very broad term. It actually summarizes all kind of things that can be done by computers instead of humans. However, there are more smaller terms in the networking, like the machine learning and also deep learning, which is actually a very sub-term to categorize the type of AI. And machine learning is mainly to use for analyze for big data, while deep learning, which contains kind of a black box by the computer, are usually like to analyze the images. So especially like the convoluted neural networks, which is a very common technique used to analyze imaging, especially in endoscopy as well. Okay, and talking about AI, it is actually everywhere. So I'm sure you all are aware of that we are embraced by the AI, like the search engines, the Siri in our iPhones, and also the auto driving, and also not to forget about the ChatGPT, which is always very helpful for us to finish some tasks as well. And talking about AI in medicine, actually is moving very, very fast. And it is generally divided into like data science and also image-based AI. So for data science, it usually like include those diagnosis related or prognosis prediction. And for imaging, actually, the frontiers of AI can is one of us, GI. So endoscopy related AI application is very popular nowadays. And also on the other side, like the radiologists and also pathologists are also using different techniques of AI, like those host like imaging, etc., to predict and also help for clinical practice. And moving back as a gastroenterologist, we always do top and tail colonoscopies. So there are many challenges in our routine colonoscopies. And one of it is actually the high polyp miss weight. And the literature actually report up to a 1/4 of missing adenomas and also around 10% for missing advanced adenomas. It means there's a high risk for these residual lesions to grow into an interval cancer. And there are actually data showing that for 1% of increment for adenoma detection rate by the endoscopist is associated with a 3% low risk for interval cancer and also 5% low risk for fatality in the future as well. So what are the reasons for the missed polyps? So I think we can generally group them into two kind of reasons. First is about the inadequate mucosal exposures. So it can be related to the location of the polyp, bowel preparation, and also, of course, the time spent in the colon and also inspection. And another reason is failure to identify the lesions, such as those very small lesions or flat lesions that may be missed by our human eyes. And one of it, of course, is related to the experience as well. So there are actually many ways to improve the adenoma detection rate nowadays. like those very tedious chromoendoscopy by indigo carmine in the whole colon, or the newer generation for the virtual endoscopy, and also like other techniques such as the water immersion, the second forward view, or the addition of a mucosal exposure. But these are all like technically demanding or somehow need some kind of training. Therefore, AI as a pair of extra eye has an important role nowadays, and actually is emerging as a additional way to improve our colonoscopy quality as well. So I'm sure that we all know that this is a bloom of the AI-assisted colonoscopy. Nowadays, there are multiple papers, randomized trials, even meta-analysis published nowadays. So in general, AI-assisted endoscopy can be categorized into either quality control, which we call the CAQ, or the computer-aided tasks. So in terms of the task, we can do lesion detection, which is called the CAT-E, or the lesion diagnosis, which we call the CAT-X. So in general, there are like three main categories of computer-aided endoscopy nowadays. So we talk about the quality control first. So one of the quality control is the landmark identification. So this is one of the applications jointly developed by CHK and also Endovision, which is actually looking into the landmark of the upper endoscopy. So like proposed by Yao Sensei, that we should always take 22 photos in our upper endoscopy. So this application may actually help some inexperienced trainees to make sure that they localize the 22 locations, and this is the end result that the system will automatically capture and also like identify the different places and also the missing part, so that the endoscopist will go back again and take a look to make sure the upper endoscopy is a complete one. Another thing, talking about colonoscopy, is of course the withdrawal speed. As I mentioned just now, a short withdrawal speed may be associated with a lower chance for adenoma detection. That's why there's another application from a China company called EndoAngel. So at the left upper corner, there's a what we call a speedometer, which is actually a real-time monitoring for the withdrawal speed. So if the endoscopist withdraw the colonoscopy too quickly, the alert will be like turning into the red color side, so that the endoscopist will be alerted and slow down, so that to ensure there's no missing point as well. And of course, the third part of the quality control will be bowel preparation, because the commonly used one will be a BPPS, which is still kind of subjective, graded by the endoscopist. Therefore, we need to find a way to standardize the bowel preparation grading, because it actually also signifies the future surveillance interval as well. Therefore, a group of China doctors also developed an AI system to grade the BPPS automatically at different segments. And it showed that for this particular application, the overall accuracy of the grading can be approached at more than 90%, which is much better than Novus or even expert endoscopists, to be a more objective way for the bowel preparation grading as well. And talking all about this quality control, the main issue is whether it can be translated into clinical outcomes. So there's a landmark trial in the endoscopy, which is a 4-arm RCT comparing the control, the CAT-E, the CAQ group, and also the combo group. And the results clearly show that when we combine all the AI-assisted endoscopy, we can actually achieve a much higher adenoma detection rate compared to the control group. So apart from the quality control, the computer can actually help us to do more, including detection or characterization. So there are numerous brands nowadays in the commercial market, including different companies, different applications, but the main task will still be either detection or characterization. So this is one of the example for CAT-E for the detection. So I'm sure you're all aware of this application nowadays because it's kind of common and also a widespread use. So for this particular application, whenever we see any polyp, which may be easily missed by our human eyes indeed, especially for these smaller ones hidden in the flow. So the computer can actually add an alert and make sure we see it and reset it. And there are numerous randomized trials, including different meta-analysis. And the major message here is even in expert endoscopists, like those very experienced, more than 10,000 colonoscopy experience, the AI is still doing some good job, which increased the overall ADR by around 10%, which is quite a consistent finding in different randomized trials as well. And our group also recently did another trial showing that the AI is actually very helpful in endoscopy training. So we randomized endoscopists in training, which is a junior with less than 500 colonoscopy experience, and then they are randomized to receive AI-assisted or standard colonoscopy. And we found that the overall ADL can be increased by 13% absolutely, and also even 40% relatively. Therefore, it may be a future trend to incorporate this into our training curriculum as well. And after all, the meta-analysis summarized different randomized trials and showing that the overall adenoma detection rate, adenoma per colonoscopy, APC, or even the proximal and sessile serrated lesions can be increased by the AI. Therefore, it is very useful to add as an extra eye to detect lesions. But talking about so many good things of AI, whether there's any bad thing about AI, so indeed there are some questionable points that we should still address before a widespread implementations. So there are a few drawbacks that can be found in the current literature. First of all, is a large randomized trial published in AIM earlier by a Spanish group showing that there's actually no difference in terms of the advanced adenoma detection rate, meaning that we are actually doing a good job, that we can still see big polyps and also advanced polyps that were not missed by us. And secondly, is that the AI got a lot of signals which may create false positive results. So different trials also showing that when we use the AI, we may result in more unnecessary polypectomy, which meaning that the non-neoplastic resection is anything that's not adenomatous or not SSL but are resected, like the benign mucosa or hyperplastic polyps. So this may be another issue to address and may be possibly addressed by the computer-aided diagnosis, which I will further elaborate. And also there's a marginal increment in the withdrawal time, very logical because when we detect more, we may reset more and do more things. So these are three major issues to be addressed before we can use AI very widespreadly. So then we move from detection to diagnosis, because what I just mentioned, the AI just detect many polyps and some of them are actually benign, but it always requires us to use additional measures like the NBI, the JNET classification, or at least the NICE classification. By looking at the NBI features, we can differentiate whether this is neoplastic or not. And with this, actually, we may consider using a diagnose and leave strategy for those hyperplastic lesions, or reset and discard for those minor adenomatous polyps as well. And most importantly, the NBI is actually very important for us to select the resection method, because sometimes when we see there's a type 3 lesion, we probably should not resect it endoscopically. While on the contrary, if the lesion is type A, 2A or 2B, we may consider ESD for even a huge lesion. But this is always difficult, probably except our Japanese experts. So maybe the AI can help us to do this as well. So this is a published paper in the gastroenterology showing that there's a new AI-assisted diagnosis system which can achieve an overall accuracy for more than 90%. and is even superior than someone that is not well trained. And one of the possible application is to use the ultra magnifying endoscope, which we call the endocytoscopy, together with a application called endobrain. So this is a very high magnification colonoscopy, which can achieve for more than 500 times. Usually we do it by virtual staining by NBI or by true staining by methylene blue. So it showed that it's actually even better than experts with a high sensitivity and over accuracy up to 98%. So this is how we do it. So for lesions that we see, we pre-stain it, and then we use our ultra magnification to zoom into the cells and the cytoplasms like this. So this is a very high magnification. So if we can maintain a good quality for the magnification like this, then we just press the button. You can see at the left lower corner that the AI will just give you a prediction value to see about whether this is a neoplastic or whether you need to touch it or you can just leave it. But still, personally, I think this is still a very difficult to use colonoscopy because your hands need to be very stable, and sometimes it's quite time consuming to do the pre-staining. So we may need further modification before it can be used generally in every endoscopist. And for the last part of the talk, actually, since we are talking about diagnosis and therapy, so indeed, our group led by Professor Dou Qi and also Hong Qi also developed an AI application. This is a preclinical model showing that the AI can actually mimic our thoughts because the AI system already know what we are doing. So they can identify we are doing the marking and also the cutting planes. And we hopefully in the future, the AI system can help to guide the very beginners to do the ESD procedures more safely and also more precisely. And this is maybe a possibility in the future because apart from our group, one of the German group from Oxford also developing AI model which can actually identify the submucosal layers and also the muscle layers and even the blood vessels during the ESD or POEM procedures, which can be actually act as a second guide for us to do our dissection and make sure the safety of the cutting planes as well. So, ladies and gentlemen, so in conclusion, I think after the talk, I think the main message is that AI is not our enemy, and instead we should treat it as our friends because what we want is actually a human AI collaboration. In terms of different tasks, we can, in terms of different tasks like the quality assurance, detection, diagnosis, or even use it as the advanced endoscopy training. So with that, I would like to thanks for your attention, and next we should move forward to our discussion part as well.
So, okay, thank you, Louis, for the very good summary about AI in endoscopy. So, in the next 10 or 15 minutes, what we aim to do is to generate some discussion. So, when I look at AI, I always think of Terminator or movies like Matrix. So one day or later, we might be completely replaced. But at the same time, we should think of how we can apply these AI. So before we discuss, may I ask a show of hands, how many of you are actually using AI in your routine endoscopy practice? So there are at least 3 hands we can see here. 4. 5. Okay, so it seems that it's already coming. So maybe we really need to think about how we should apply AI and safety or drawbacks with the using of the AI. So, I mean, I ask first of all, I'll ask our international faculty, how do you view what we should do with AI, or what are the different drawbacks that you can see with AI. So maybe Sano Sensei.
So thank you, James. No, Luis. It's very educational presentation, and I have question because artificial intelligence for the training doctor is very useful, and but for me, I'm getting older, and maybe over 60 years old or 65 years old, my vision maybe getting worse. So I guess so. The AI support is not useful. Is useful only the trainees, but also our older age. So yes, because yes, because in Japan, so driver license over the 75 years old people should receive the special lecture, and maybe over 80 years old, right? So maybe most of people lost their license, because vision activity. So then, how about the for the expert is not always expert, all the expert, I don't know. So because vision activity is getting worse. So is there any study about this?
Very difficult to answer. I think in general, for at least in the lower GI field, there are many papers suggesting it can even increase the performance in terms of the ADR in the expert and endoscopist, and paper also studying the use AR show activity. Use for AI in endoscopy, because the endoscopists may become very dependent on the technologies, which we definitely need to address this potential concern, because we can push forward this technology.
I want to add to that. So I think for Cat E that Lewis has presented about improving polyp and adenoma detection with AI, there are three concerns on my part. Number one is that there's recently been at least 2 studies that show that AI not only does not improve ADR, it may actually worsen ADR. So there's one latest study that shows that it worsens ADR. And I think one of the reasons is that these studies are actually pragmatic implementation studies. So they are randomized by the pragmatic, meaning that they leave it up to the discretion of the endoscopist to use or not to use Cat-E. So this is a real world setting. The second is that actually Cat-E studies are not really done in screening colonoscopy populations. It's actually all comers. So it tends to be symptomatic patients who tend to have a higher polyp burden. There's only one study or 2 studies that I'm aware of that actually look specifically at the colonoscopy screening population, and I think one of them shows that there's no benefit. The third, of course, is whether what Lewis had brought up, the scanning. So for us, we tend to have a bias towards the center of the screen, and AI actually helps us to scan the periphery. But in that study, what it shows is that with the bounding box appearing, we tend to focus on what the bounding box is looking at. And then we become even more biased towards center or towards where the box appears, and then we completely leave out scanning. And that is a concern because no Cat-I system or Cat-X diagnosis was trained with an adequate data set of SESAS-rated lesions. Because SSLs, with the exception of maybe Australia, only account for about 3 to 5% of polyps resected, not even detected, but resected. And so maybe in Australia it goes up to 20%. But so in most data sets, because most of these Medtronic GI Genius is Europe, US, and I think Olympus Fuji is mainly for Japanese. So most of the countries the data set comes from don't have adequate SSLs. So it cannot. We don't really know the benefit of in post colonoscopy colorectal cancer decrease because of these three factors. So my question to maybe the faculty and to Louis, because he gave the talk, is that what do you think is the best type of clinical trial? Which data would you go by? The RCTs or the pragmatic kind of implementation? Because I'm a supporter of Cat E, but looking at the two evidence, depending on what design you use, the results are actually very dichotomized. So which will you go by if you were to convince the audience to use AI?
So yeah, so ultimate goal is so survival. Uh, one arm is so colonoscopy only, and one arm is so the colonoscopy with AI, and the final goal is mortality. But maybe it's too long, so the initial primary goal is incidence of the colorectal cancer after the received colonoscopy. So we follow the 10 years later or something. It's the best way to prove the effectiveness.
Okay, I actually agree with this.
I tend to agree. I fully agree with this. Actually, I remember Yoshimori Sensei also conducting a huge mega trial for a 10-year outcome in terms of AI or no AI screening colonoscopies. We eagerly wait for the trial to confirm the effectiveness of AI colonoscopy because it's ultimately we look at outcome, which is the CRC-free survival instead of this detection rate. But to me, I think the current issue is still that we are not that bad because we still can pick up advanced adenomas. But the question is whether we additionally pick up these small adenomas or flat adenomas with beneficial in terms of the long-term survival. That's one question to be addressed, and I believe we need a lot of prospective data to answer this question. And also, secondly, I think the issues is how can we implement this? Because as James mentioned, the implementation trials are mostly negative trials. So, but we need to think about a way for how to interpret this because maybe there are a lot of bias in the real world setting. So, we really need more well-designed implementation trials to confirm or reject this statement.
Can I comment? So I think that this design should be randomized control trial, AI assisted diagnosis versus AI assisted diagnosis. But still, how to implement or how to use and the algorithm still really adequate, optimal or not is not yet well established. So very difficult to compare. I think in the future or in general, I think AI is very beneficial for endoscopists, especially non-experienced or young endoscopists. But maybe once for experienced doctor, it's okay. Even though AI provides some wrong information or wrong diagnosis, expert can, correct the actual diagnosis. But young doctor, once they really believe in such kind of technological answer, maybe we can achieve some wrong clinical practice. So, and also, I think AI should be update every time. Like Google, because we already Google search and the Google map, we already rely on Google such kind of AI system, but that they are always updating. We have to rate the
place was correct or road map was correct or something. But in medical systems, it's sometimes difficult to update such kind of algorithm. So, do you have any information how we can make such kind of system in a AI?
Thank you, Dr. Uedo. I think he's brought up 2 points that are very important. So in every AI study, according to the Spirit AI consensus, we are supposed to report the technical aspect and the operational environment. And I think Louis, myself, we do AI studies, and I think we are guilty of not reporting fully the technical aspect. So we're supposed to give a detailed description of like how it was trained. And sometimes when we validate commercial systems, we ourselves don't know how it was trained. So we don't know at that point what it was trained on and whether there will be updates. So that's number one. Number two is that we're supposed to specify the operational environment, means how it was deployed. But of course, in RCTs, we are worried that the reader
Đây tôi qua đây.
Vừa xong rồi, viết đâu mà.
and so that the readers can interpret not just this works, but it's because it's in this specific clinical environment. The updating is difficult because it's very tedious. You have to collect, send to a central location, and train. So the only solution is decentralized training.
Ít gặp. Người thông thường người quản lý mình ý gặp cái này thông thường người nó nhiều rất nhiều. Người bố mẹ quản lý được
So they can just not sharing the raw data, but instead they share the trained algorithms, and the overall algorithm can learn different algorithms. So this may be the way to go in the future, and also, if possible, open access raw data. At least we need to look at what are the raw training materials that are included, which I agree this is very essential. Yes, practically speaking, going back on a clinical aspect, I think a few important things I would like to emphasize. First is, as the endoscopist, you always need to be aware of the good and bad of the AI. For example, Louis mentioned, and James also mentioned, SSL is something that is lacking now for the AI. So a few weeks ago, Dr. Raj Singh actually showed me a very nice video of him using an AI. There was a large SSL and a small adenoma. So the AI kept splashing that super small 3 mm adenoma, but the SSL was remained unseen the whole time. And if you're an inexperienced endoscopist, or if you rely on AI too much, this is something that can happen. You will miss the SSL, and you remove a minute adenoma that may have even no significance to the patient. And the other thing is, he mentioned that the IC valve was lighting up like a light bulb whenever the AI went there. And that's the other thing. So that also comes back to training, I think. So how should we train our endoscopists with the AI in our hands, or as one of our technology? So with that, I would also like to ask, how would you vision the training in the future with the application of AI? So how should we train? I think at the end, the endoscopists should still have the same degree of technique and knowledge as we have today. We should not be replaced by AI. So how should we train it? Because the more AI is helpful, the more difficult it is for us to train new generation endoscopists. So I would like to ask Sano Sensei, our chairman, what do you think? What should we do?
It's very difficult. Yes, actually, I use AI my colonoscopy, but it's very useful when I'm tired, because in the afternoon I'm getting tired. So it's very supportful, very useful to be so to have so confidence for me. And anyway, so and in ANBIIG, this workshop, we have to give you so many lectures, but the feedback we don't. So after sending the lecture, and so many AI developed by expertise doctors, so that our brain and our experiences inside in the AI, so it's learned in your practice, daily practice by AI, and because not only so detection, so diagnosis. But I cannot do some best way. But anyways, AI is very useful for self-learning.
Probably the best training is any tutorial, one-to-one master and learner training. But it is very difficult to make it real in our clinical practice. For example, number of trained good experts is very limited. Maybe in Japan we have a lot, but in some country, in some rural area, very difficult. But and also, as just mentioned, that the human always retire and no time, not enough time. So maybe, but some part AI can take place, such kind of things. So like a virtual teaching and also AI training can still help more trainers. But maybe final feedback or final check should be done by human expert. So maybe how to make such kind of curriculum or system is most important in the future, I think.
Yes, thank you. So I still remember listening to Yu Honggang. He mentioned that the reason why he used AI or he developed all these AIs because he thought that training 13 million or 13 billion of Chinese doctors is much more difficult than training one AI than send it out to everybody in China. So that's his vision. But anyway, I guess we had a very good discussion about AI. So the time is coming up, so we will move on to the next session. So may I invite Dr. Stephen? So you're chairing our next session. So he actually joined our TTT workshop, so he's now coming to contribute to us on the ANBIIG activities. So thank you. Yeah, my pleasure to be here, and my pleasure to introduce the next speaker, Hon Chi, my brother. And so he is the assistant professor of the Chinese University of Hong Kong and the director of this course. In the following time, he will be giving a lecture on the detection and characterization of early pharyngeal and esophageal cancer. So the floor is yours. Okay, thank you. So may I have the slides? So this is will be a short lecture because I think some of you may have read it, the video online. So I don't want to bother too long. But I would like to emphasize how we can detect and characterize early pharyngeal and esophageal cancers. So to begin, I think we have to know that esophageal cancer remains an important disease, especially for squamous cancer. Even in Hong Kong, this is still the dominating cancers, and also one of the deadly cancer, because most of these patients who were diagnosed, even in Hong Kong or many areas, were diagnosed at a very late stage. So we would like to see how we can improve our detection and diagnosis of these cancers. So one of the important concepts is field cancerization, because basically you all know that squamous cell mucosa comes all the way from the oral cavity to the oropharynx to the hypopharynx and esophagus as well as the trachea. And it has been well demonstrated that all these mucosa shares the same type of risk factors. So, and they would develop similar type of cancers which is associated with certain carcinogenic factors. So pharyngeal cancers and esophageal cancers are actually connected, and they may happen together. So we need to know who are the high-risk groups. So for instance, older men okay, heavy drinker, smoker, those who are Asian flush or ADH deficient. So these are the patients, a target clinical group that may benefit from screening. And also, if you are using regularly the glucose iodine chromo, then those patients who have multiple voiding areas, again, would be those at risk. More importantly is all of these cancers, when they are at the early stage, they do not have actually any symptom. So maybe we are obliged to think of some form of screening or some form of endoscopic diagnosis whenever we encounter these group of patients. So this is a very nice demonstration of how the flushers would have a dramatically increased risk of cancer. So if you're a flusher and even if you flush but you still drink alcohol, so these are the highest risk patients because at the end of the day, the alcohol would accumulate in the body and then transform into the carcinogenic matters. So go back to diagnosis of GI cancer. So this is a very common theme for all GI cancers. We always try and detect abnormality, followed by differentiation, whether this is a carcinoma or a non-carcinoma. And if you suspect a carcinoma through endoscopy or other methods, you can also do a staging of the extent and depth of invasion for the carcinomas. Using white light endoscopy for detection of esophageal SCC is actually notoriously difficult, and you have to be very vigilant when you're doing white light endoscopy because there's usually only very subtle changes. So color changes, disruption of the normal longitudinal veins, maybe some epithelial layers of the esophagus. So there are very subtle change, or maybe some elevation or some depression. But honestly speaking, even with expert's eyes, it's not easy. So that's where image enhancement may help because it has been well documented that with narrowband imaging, you can actually see these cancers much more easily by looking for brownish discoloration with a demarcation line. And also within the brownish discoloration, you will see some abnormal vessels. So if you're not using a magnified scope or near focus scope, what you can see is multiple large dots because these dots actually represent the IPCL, the capillary loops within the mucosal layer, where if they are abnormal, they will become dilated and thus appears as a larger area of dots. So the reason for brownish discoloration has been investigated before, and the main reason that has been postulated is because of the thinning of the epithelium. So because of the thinning in the cancerous area, so the color that would appear by shining blue and green lights onto the mucosa would change from a slightly greenish mucosa to a brownish mucosa, and this has been found in this study in the past. So we talked about IPCL. So what is IPCL?